There is a lot of general pediatrics. Now, some of what we have talked about with adolescent medicine has already been covered in these areas. And what we will talk about on Saturday morning, immunizations, is a critical component of the board content within the area of general peds. So if you take general peds, adolescent medicine, and immunization, that's a big chunk of your boards. And again, as I said earlier, infectious disease is the biggest proportion of all the specialties. So I guess I said that to say, hang in there. It's almost Saturday, but we still have a little bit of work to do. All right, so let's look at some normal growth and development. So just some simple things to remember. Birth weight is usually regained by 10 to 14 days of age. One prefers certainly not to see a weight loss of more than 10%. Of course, that depends also on the birth weight itself. It depends upon the bilirubin status and the like. But from an anticipatory guidance perspective, we are doing parents a real disservice if we don't remind them that they can expect a weight loss in a newborn, especially first-time parents, and they see that their baby has lost weight. That could have some real negative impact upon parents that are already tired and already struggling to adjust. So that's a critical component of the anticipatory guidance that should be provided in the newborn period. Weight should double by 4 months, should generally triple by 12 months, and quadruple by 24 months. Really an incredible amount of weight gain when you consider percentages. And so what they are not going to ask you on your boards is birth weight should triple by 4 months, 6 months, 8 months. But what they will do is they'll present a birth weight and then present a 4-month-old. And for example, if that 4-month-old is a pound above birth weight, then that's your indication that something is wrong with this child, and you're going to have to look further into this. So a lot of general peds, be it developmental or be it growth, is important information to know so you can glean from the information that they are giving you on the exam as to what's normal and what's abnormal. In terms of height, gain is about 50% within the first year, double by 4, triple by 13 years of age. In general, preterm infants can be plotted on standard growth curves. A newer recommendation is that from 0 to 2, WHO growth curves should be used, and 2 and over CDC growth curves should be used. And the benefit of using the WHO growth curves is that they provide much more information in many more individuals that have been breastfed. And because breastfeeding is becoming more common, it's thought that the WHO growth charts are in general preferred for the first couple of years. Most preterms will catch up during the first year of life. You can, for certain preterm infants, especially the very low birth weight infants, consider that 2 years of catch-up would still be appropriate before you start to worry about underlying organic causes. Always adjust for prematurity until about 2 years of age, and the adjustment for prematurity will make your growth charts much more accurate. Begin to use BMI. Certainly always use BMI no later than 5, and use weight to length for the first 24 months and then transition between that period of time. And try to measure height as soon as you can from a standing rather than a recumbent position. I imagine I know this is what we do, you have a child on a piece of paper and they're wiggling and you try to make a mark here and by the head and make a mark here by the foot, and that's far from accurate. So if you can get them to stand, or if you have one of those little fancy length measurements, but again, they're wiggling around. So yes, it's not particularly accurate, but it is the best that we can do. This same slide I included yesterday, excuse me, in the adolescent talk, just to remind you, these are the definitions that you should keep in mind as you sort through. Again, very important for anticipatory guidance that we'll be talking about. How many of you measure the head circumference 3 times? Anybody? That's great. Good for you. I'm not, well, I guess I've measured the head, I've certainly repeated the head circumference, but on a routine basis, I've not done that. And, but that is the recommendation. Again, to get a more accurate measurement, and obviously this is a little bit more difficult, especially in young girls who have braided hair or who have bows and the like. But the recommendation is to make 3 measurements and take the greatest of those 3 measurements. So let's look at this. We've got a 6-month-old who presents for a well-child checkup. New family in town. Height and weight today are plotted at the 5th percentile. By history and by physical, he seems fine. What should you next do in terms of the evaluation of this patient? Obtain old growth charts, get a basic metabolic panel with a venous pH, urinalysis and culture, nutritional consult, or thyroid function tests. Right, good. This is always the default answer. Get additional history before you start working up a child with failure to thrive or a child with any abnormalities in his or her growth parameters. All right, you certainly are familiar with the growth charts. I'm just including them here for completeness sake. And again, the first step, get old measurements. If you see a growth chart on your exam, look at it. How is it changing over time? Which direction is it moving? And most importantly, is it crossing percentiles? If you see a growth chart, for example, of someone with hypothyroidism, oftentimes you'll see that the weight is beginning to cross percentiles up, and the height is at least staying steady, and oftentimes over time, obviously because the child is getting older, the percentiles are dropping. So that's a key thing to look at, and you'll probably see a couple of growth charts on your exam. I can see a growth chart, for example, for hypothyroidism, perhaps a growth chart for someone with a malabsorptive disorder like celiac disease or inflammatory bowel disease. Others that you could conceivably see would be related to an underlying chronic disease that is yet to be diagnosed. And celiac is probably the one that's going to take the longest period of time in between onset of illness and diagnosis of illness. There are special growth curves available, especially for individuals with particular syndromes. Again, it's surprising to me how much controversy and discussion there is in the literature about when to use particular growth charts for premature infants and when not to. Most of it centers around the very low birth weight infant rather than the infant, say, born at 35 or 36 weeks of age. Okay, in terms of health supervision, what they're going to want you to do is tailor your counseling towards age and towards the reason for the visit. So if the reason for a visit is a bump on the head in an 8-year-old who's been skateboarding, then obviously you want to focus your health supervision on safety, helmet use, and the like. So it should be prioritized in terms of the context of the visit. and the age-specific advice that is most relevant for that particular patient. And you're well familiar with some of the common issues that will come up, and you're well familiar with what to discuss at various visits. And so here's just one of many examples I could have put together. 2-month-old should be advised about the following that are listed here. And all of these are important, be it safety, be it nutrition, and also included in this should be, okay, now I'm not going to see you again for another 2 months. So by the time I see you again, your child will be. And then you review with them the expected developmental milestones that you will see at the 4-month visit. Focus especially on car seat safety. It's likely that you're going to get a couple of questions about car seat safety in terms of the recent recommendations. Rear facing until 2 years of age. Forward facing at 2 years of age or even older if they haven't yet met weight and height maximums. And remember also that these apply to children younger than 2 years of age who have outgrown the rear-facing weight and height limit of the seat. So it's important as you discuss this with patients that you tell them to go into the manuals and make sure what the limits are. And then belt positioning in a booster seat until the vehicle seat belt itself fits appropriately, which is usually around 4 feet 9 inches, which I think is also the minimum at a lot of rides at Disney World for some reason. I'm not sure. But I know my granddaughter was not able to go on a couple, and she was not a happy camper. But anyway. Important issues to address are here. Again, they're pretty straightforward. We're going to talk a little bit more about dentistry in just a second. Begin to talk about alcohol and drug use around 10 years of age. That also, remember from yesterday, is the age where you should begin to encourage parents to give you permission to meet with their children alone, to begin to establish the relationship that you hope to have so that individual will share with you difficulties that he or she may encounter as they grow into adolescence. So what are the current recommendations for routine dental care? Ideally, a dental home should be established by 12 months of age. That doesn't always happen, to say the least, in the real world. But those are the recommendations. High risk, preferably by 6 months of age, and no later than 6 months after the first tooth erupts. So, who's considered high risk? Those who with special needs, who have a family history of high rates of dental caries, who have significant abnormalities on their exam. Certainly the most common, unfortunately, is sleeping with a bottle. The bottle is propped at night, or the child is breastfeeding continuously through the night and co-sleeping, which is another issue that you want to discourage. Know this not because they're going to ask you it, but because, again, on a physical exam, you may be given a 12-month-old with no teeth, and then something is awry, and that's going to be important for you to know about. How about fluoride? You should not use fluoride until 2 years of age, unless there's an increased risk. A rice-sized smear is sufficient. And then after 2 years of age, the piece of rice becomes a pea. And then obviously, as you're discussing this with parents, encourage them to help their child to spit and not to swallow, which is much easier said than done in a lot of cases. How about fluoride supplementation? You're going to have to be given the local fluoride content in your test question because the administration of fluoride and the amount of administration is dependent upon the local water source. And so you will be given that, but once you have that information in hand, then you should know this chart so you can make appropriate recommendations. Fluoride varnishes. How many, some of you using fluoride varnishes in your practices? Yeah, and that helps, especially because so many patients are not able to establish a dental home by 12 months of age, and they work pretty well. They can decrease, studies have shown that they've decreased dental decay rates by up to 40%, and they're administered during well child visits, and it's something that is currently receiving more recommendation. Okay, common screening tests. We did some of these yesterday. One screening test that I want to mention that's relatively new is that in the newborn period, at 24 hours of age or older, but certainly prior to discharge, children should have an O2 sat to detect underlying severe cardiac disease. So this is, for example, a child with a hypoplastic left heart, and as you know, those children can look quite well for the first 24 or 48 hours. So it's routinely recommended now prior to discharge that all children get an O2 SAT. Now, vision screening, what's normal? Red reflex, as I tell our students and our residents, this is one of those tests that you'll do thousands of times during your career, and the red reflex will be abnormal probably less than 5 times. But you'll be very glad that you did that, because you certainly don't want to miss an abnormal red reflex. So here's an example of bilateral congenital cataracts, which obviously would make the red reflex absent. And also a little bit older, retinoblastoma, or the so-called cat's eye, the whitish discoloration that parents may notice that will bring them to see you. A little bit older individuals, you can do the cover-uncover test, and that test is a procedure where you cover and uncover a single eye as the child looks straight ahead. This is so easy to say. 2-year-old, look straight ahead. I'm going to put my hand here, stay still for 10 seconds, and then I'll move it. But that's what it says, so you make that attempt. And the positive screen is movement of the uncovered eye when the other eye is uncovered. And that is something that you could be asked about. And this positive screen indicates the presence of strabismus, and you should get referral to an ophthalmologist right away. Frequency of vision checks are outlined here. I honestly, there are some charts where pictures are used instead of letters for younger children. Most of the time, the child's going to have to be 5 or 6 and very cooperative and precocious and bright before they can use the more typical eye chart that is here. So who do you have to keep in mind is at high risk? So a very premature infant, certainly because of retinopathy of prematurity. The presence of congenital cataracts, metabolic diseases. Remember that galactosemia is associated with cataract. A classic board question is a failure to thrive child who has a cataract, who presents to the emergency department septic, and the blood culture is positive for E. coli. It's a very common presentation board question on galactosemia. Significant developmental delay, neurologic problems should also be referred. And in older individuals, remember that systemic disease, remember from the rheumatology lecture earlier this week, certain types of JIA are associated with uveitis, Behçet's disease, inflammatory bowel disease, ankylosing spondylitis can also be associated with uveitis. Now, tips for your boards. Since we're talking about congenital cataracts, remember that congenital cataracts can be seen in congenital rubella. And as we heard earlier today, if the individual patient has recently immigrated to this country and has a cataract and has a blueberry muffin rash, that's probably rubella. Now, an example of a board question, I know I've said this a lot, but I want you to get used to how to study, is let's say they show you a picture of someone with a cataract and they have immigrated to this country. And this might be the question. In the child pictured here, which one of the following best describes the most likely murmur present on physical exam? And you'll search down, and what you'll see for one of your choices is a murmur consistent with a PDA. So, number one, you have to remember that cataracts are associated with rubella. Then you have to remember that rubella is associated with PDA, and then you'll have to remember what a PDA murmur sounds like. CNS calcifications, think toxo and CMV. And as was mentioned earlier, CMV is periventricular and toxo is scattered. And the way I remember that is CMV has a V, ventricle has a V, and periventricular. If you see the term grouped vesicles anywhere, that is a giveaway for HSV. Bony changes and hemorrhagic rhinitis is syphilis. This is a child abuse look-alike commonly covered on the boards. 4-month-old comes into the emergency department refusing to move the right arm. They might set up the scenario to make you think that this child is at increased risk of non-intentional trauma, and then they show you an x-ray. And there's not a break, but what there is periosteal elevation. And it's the periostitis that is causing the pain, and that is so-called pseudoparalysis. And then if you see abnormalities in the limbs and in the eyes, that is congenital varicella. So if you have a patient with microcephaly, rash, prematurity, intrauterine growth retardation, hepatosplenomegaly, they're setting up a scenario that suggests a congenital infection. And then there'll be bits of information, be it eyes, a CT scan, a plain X-ray, or a picture of an abnormal limb that will help you sort out which one of the particular torch infections you may be dealing with. It was mentioned earlier also, and I want to reemphasize this because this is commonly on your boards. When do newborns need to be treated with VZIG when mom gets chickenpox? And it's 5 days before and 2 days afterwards. Now here's the crazy way I remember that. Chickenpox. Chicken has 7 letters. The first 5 are chick. That's the 5 days. The last 2 are in. Chicken. That doesn't sound too good, but that's how I remember it. I used to remember, I was born in 1953 and I subtracted 1, but I didn't want to tell you how old I was since I just turned 60. So if it helps, great. If it doesn't, then forget the chicken. But I thought that was pretty good. All right, hearing screen. Deafness is pretty common, unfortunately, and early detection is necessary for obvious reasons. You want to maximize linguistic competence. All children should be screened, and I'm sure all children are screened in your newborn nursery before they leave. But importantly, as soon as possible, but no later than 3 months, should they have an audiologic evaluation to confirm. And there is not a recommendation by the AAP in terms of which specific hearing screen to use. In my experience, most nurseries use the auditory brainstem response, but again, either are approved by the AAP in terms of hearing screen. Whenever you see a statement that the parent is concerned about language development, never choose as the option return in 3 months for recheck. Okay, so any parental concern should always be addressed, and usually in regards to how to address that, although at times it can be reassurance, certainly with a parental concern about hearing and language development, that is not the case. There's a history of congenital infection, bacterial meningitis, significant head trauma, and various syndromes. Individuals with craniofacial syndromes, some of them are listed here, Pierre-Robin, Apert-Cruzans, all are at increased risk of hearing loss, as are children with trisomy 21. I'm sure all of you are familiar with following patients with trisomy 21 in your offices. Their ears are very difficult to examine. Their canals are tortuous, they're small, and eustachian tube dysfunction is very common, and hearing loss is very common in those individuals. All right, now since we're talking about deafness, I'm going to give you another common tip that centers around deafness, and that is someone who has a syncopal episode and there's a family history of deafness, or there is an individual history of deafness. That is a very big clue for prolonged QT syndrome. Because the recessive form of prolonged QT syndrome is associated with deafness. So just one thing to keep in mind, since we're talking about hearing screens, deafness is one of the things that may show up in a patient with syncope, and that will help you in your differential diagnosis of syncope. And again, these are the individuals who typically pass out during a sprint. All right, blood pressure screening is pretty straightforward. Again, I'm not going to spend a lot of time on this. Certainly, if you're told that there was a history of an umbilical artery catheter, that's a big hint that hypertension is a problem. And routine blood pressure screening is not indicated unless individuals have these particular risk factors that are listed here. Verify it by 3 separate readings over a period of at least 7 to 10 days. Use norms for sex, age, and height. And again, I mentioned these yesterday in the adolescent talk, but just know the different stages of hypertension that have been more recently established. Okay, so which one of the following blood tests is most likely to identify the cause of these radiographic findings? An ANA, an RPR, CBC with smear, parathyroid hormone, and ionized calcium, or a lead level. Okay, good. So these are pretty classic lead lines. As you can see here, usually deposited at the ends of the bones. And so when do you screen for lead? The lead lines themselves are due to chronic long-term lead poisoning. There may be multiple bands that indicate episodic exposure to lead. And so you should perform a verbal risk assessment at multiple ages during the first 6 years of life, and move forward with additional testing if a response is either positive or I don't know. And the AAP recommends, and Medicaid in most states requires, blood lead testing, oftentimes with a hemoglobin, at 12 and 24 months of age. So, what are the questions that you should ask to assess for lead intoxication? The age of the house, recent renovation in the house, a family history of elevated lead, folk remedies, certain potteries, certain occupations. Lead stained glass is probably the most common one that you'll hear. But these these questions should be asked, and any one positive answer or even an unsure answer should lead to testing, because the threshold has again been lowered. Again, to show my age, when I was training, this was 25, and it went to 20. Did somebody groan when I said that? It might have been 40, I don't know. So 20, then down to 15, then down to 10, now it's down to 5. And it's important to realize that the chelation has really pretty well been kept steady at 45, but now intervention is recommended as low as 5 micrograms. Venous blood sampling is preferred, so certainly if the initial screen was a capillary sample, you're going to want to follow up that capillary sample with a venous sample before moving on to more aggressive intervention. So here's a typical smear. You can see the basophilic stippling that is not pathognomonic of lead poisoning because it can be seen with other etiologies as well. Note also how hypochromic the majority of these cells are, and that is pointing out the fact that oftentimes lead intoxication is associated with iron deficiency anemia. So this is an example not only of basophilic stippling, but of a smear that's consistent with iron deficiency anemia. So when do you screen for anemia? The AAP recommends that you screen everyone at 12 months of age. Again, oftentimes that is repeated at 24 months of age along with lead, but the specific AAP recommendation is only at 12 months of age. But that said, since Medicaid oftentimes requires screening at 12 and 24 months of age, children in day-to-day practice are oftentimes screened twice. You may want to screen for iron deficiency anemia earlier if there's a history of cow's milk intake early on. And again, high-risk infants are certainly going to at least be screened more frequently during the first couple of months of life. But in general, in an otherwise well infant, the first hemoglobin screening should be around 12 months of age. And then those who are at risk because of dietary illnesses or chronic diseases or socioeconomic circumstances should indeed be checked more frequently. Remember that individuals on vegan diets, iron, calcium, zinc, B12 are the 4 most common nutritional deficiencies associated with some diets. And then if you have, for example, getting back to how we finished up with the adolescent talk, targeted screening in the adolescent population for individuals with chronic diseases, eating disorders, and menstrual irregularities that have led to increased frequency of menses. Urinalysis, not indicated. It's always going to be your answer. Now, there was a long talk on metabolic diseases, and I won't even begin to pretend that I could repeat all the information that was in that talk. Depending on where you live, you should certainly be familiar with what particular newborn metabolic screens are tested. Remember that PKU and hypothyroidism, the blood sample should be obtained at least 24 hours of age. If it's obtained prior to that time, it is going to need to be repeated. Now, autism screening, incredibly important. The issue that surrounds autism and vaccines, the concern, the very legitimate concern of any parent with an autistic child has really brought to the forefront over the last 5 years the necessity on our part in general pediatrics to do all that we can to screen, to identify individuals early on with signs and symptoms of autism. So routine screening is recommended at 18 and 24 months. Because of the obvious importance of early recognition. Most people use the modified checklist for autism in toddlers, and all responses should be yes except for the 3 that are listed here. If you ever wondered your child might be deaf, any unusual finger movements near his or her eyes, or very sensitive to specific noises. A score between 3 and 7 should prompt additional testing. A score of 8 and above should prompt immediate referral. So there are 3 areas that you are specifically inquiring about: social interaction, language development, and behavior. In terms of social skills, beware of failure to respond to name, poor eye contact, or appears not to hear. Lack of enjoyment in terms of cuddling and bonding. And as they grow older, obviously, a preference to play alone and a apparent indifference to the feelings of others. Language delay, loss of previous language, language milestones, lack of eye contact when speaking, and sort of a sing-song rhythm or a language that is exemplified by repeating back either what the child says or what the child hears. And then an inability as they grow older to carry on a conversation, and again, repetition of words. Repetitive movements and rituals. I think we probably all had a patient who had very specific rituals which were incredibly important. And when that ritual is disturbed, then the child becomes very, very upset. So one of my favorite patients takes about 10 minutes to line up all of his trucks before going to bed. And if one of his siblings comes in and in any way changes that line or kicks that line, the young man has terrible difficulty handling that and takes sometimes hours to calm back down. And they're very interested in parts of an object, not wholes. My wife had an individual with autism who had an absolute fascination with calendars. I've had a patient with an absolute fascination of vacuum cleaner parts. So that should always be a potential red flag of an unusual interest in an inanimate object, oftentimes knowing lots and lots and lots about that particular object. Switching over to immigrant children, if you have something on your exam that talks about a recently adopted individual, think infections, as was mentioned in the lecture today. Most should be screened for hepatitis B and C, for syphilis and HIV, tuberculin skin testing, and remembering is 5 positive, is 10 positive, remembering the categories that we've discussed earlier, and a CBC with differential. Many larger cities now have an individual within their infectious disease division that either specializes in the care of recently adopted children or can certainly serve as a resource for you. And then some individuals will need parasitic testing as well. Okay, so let's talk a little bit about feeding, supplements, and nutrition. Obviously, the AAP is a strong proponent of exclusive breastfeeding for the first 6 months, followed by the introduction of complementary foods somewhere in the neighborhood of 4 to 5 to 6 months, depending upon the particular child. And their statement is that mom continue to breastfeed as long as mutually desired by mom and by baby. Lack of support and inability to deal with common and usually easy to address problems. So if you do work in newborn nurseries, oftentimes there is a particular nurse who is an expert at discussing breastfeeding problems with moms, and from an anticipatory guidance standpoint, it's invaluable, and also from a health standpoint, because an inexperienced mom who is struggling with breastfeeding may not realize that, for example, her young baby is using the breast more as a pacifier, but she's not been told to listen for the child swallowing and to make sure that the child has a appropriate grasp of the nipple. Simple things that are critical and anticipatory guidance that can prevent subsequent hospitalization for dehydration. Lots of proven benefits of breastfeeding. They're all listed here. And because there are so many benefits, I think what you might be asked about is when can you not breastfeed, because it is so unusual that you cannot. Galactosemia is the major metabolic disease, and in the United States, mothers who are HIV positive. That is not the case in less developed parts of the world, because there is more concern about contaminated water that might be mixed with formula. Breastfeeding is not contraindicated, so galactosemia is one of 5 choices, and your other choices are probably listed here. So surface antigen positive moms, hepatitis B, hepatitis C, an illness, and the like. So I would definitely know the very few contraindications to breastfeeding. Probably the one potential contraindication that is most often asked about is the mom who is hepatitis B surface antigen positive. And that's also a very common source of questions in regards to immunization and in regards to how hepatitis B immunization needs to be altered in newborns whose moms are surface antigen positive. And we'll talk about that when we do immunizations. All right, so importantly also that the vast majority of babies with hyperbilirubinemia should be encouraged to continue to breastfeed. All right, so a SOE formula is indicated in which one of these infants? A premature infant, an infant with secondary lactase deficiency due to prolonged gastroenteritis, an infant with a documented cow's milk protein allergy, an infant with colic, or an infant with a family history of atopic disease. Prolonged gastroenteritis. Okay. Prolonged gastroenteritis. Many children do not need a SOE formula with an acute GI illness, but it is one of the recommended scenarios where SOE formula is indeed appropriate. SOE formula should only be given to term infants, fed to children whose parents do not want to use any animal products. Again, galactosemia, galactosemia, galactosemia. And most infants, not all, but most infants with acute gastroenteritis can be fed human milk or standard dilutions of cow milk-based formulas. Keep in mind that up to 15% of individuals with a cow milk protein allergy will also be allergic to soy protein. So if you have a documented cow's milk protein allergy, you should switch to a hydrolyzed protein formula derived from cow's milk, not a soy formula. So preterm management of colic, that's just setting the parents up for failure. If they're fussy, we've all seen the child who's bounced from formula to formula to formula, and that, in my experience at least, just adds more and more frustration and angst to already worn out parents. Cow's milk should be delayed until 12 months of age. Then 2 cups of milk are generally adequate. Whole milk is recommended for ages 12 to 24 months with a big but. And that big but is that reduced fat 2% milk is now recommended for all ages 12 to 24 months at risk of obesity, family history of high cholesterol, and the like. So many individuals are automatically using 2% milk between 12 and 24 months of age, and that's a relatively new change. And then over to either skim milk or 1% milk. Now, what's the problem with cow's milk? If you're presented with an infant with a cow's milk allergy, they may present to the emergency department with a heart rate of 120, in respiratory distress, with peripheral edema, and lo and behold, a hemoglobin of 6. And what happens is that the cow's milk causes occult GI blood loss, and the iron that is available in cow's milk is not bioavailable. But because these children are fed cow's milk for long periods of time, the children are able to compensate. And finally, they can compensate no longer and go into congestive heart failure. The lowest I've seen is a hemoglobin of 4 in a child from an impoverished family who were doing their level best to care well for their child, but all they could afford was whole milk. And she came in very, very ill, and those children are difficult to treat because you have to correct their anemia very slowly. Otherwise, you'll make the heart disease even worse. So be cautious about cow's milk. Include that in your anticipatory guidance, and you should also include in your anticipatory guidance the problems associated with excessive intake of juices in terms of causing osmotic diarrhea and the like. So there are specific recommendations as to how much juice to use. Feeding issues for toddlers. Toddlers should be encouraged to establish a routine, a variety of fruits and vegetables. Don't get caught into the scenario that you've got to sit there until you finish your peas or you finish your potatoes. Given small portions, a reasonable period of time to eat, and then the meal is over. And this is a great opportunity to encourage parents not to allow their children to graze and just to snack on things throughout the day, because clearly that will negatively impact their ability to have a meal. All right, all of the following are true about the most recent recommendations for vitamin D, except, again, this is a not question, all infants should receive vitamin D supplementation. The daily recommended dose is 200 IUs per day. Breastfed babies are at risk for vitamin D deficiency. Supplementation should begin soon after birth. Supplementation should continue through adolescence. Which one of those is incorrect? Okay, good. So daily recommended dose is 400 international units per day. And the problem is there's limited dietary sources of vitamin D, inadequate sunshine exposure, and sun exposure isn't recommended. So it's kind of a double-edged sword. You're supposed to have sun, but if you have sun, you get skin cancer. So the vitamin D issue has really come to the forefront. So exclusively and partially breastfed infants should receive 400 international units a day. Adolescents having less than that same amount should have additional vitamin D fortified through milk and through foods. And children at risk of vitamin D deficiency may need even higher doses. I was talking with one of you all earlier, and vitamin D deficiency in adolescence it's almost daily, especially in our adolescent population that is struggling with type 2 diabetes and obesity. So in our clinic, our routine initial screen for metabolic syndrome and for associated problems includes a vitamin D level, and almost invariably vitamin D deficiency is present. So it's a real issue. Iron deficiency, the most common micronutrient deficiency in the world. Again, another example of multiple hypochromic microcytic. You can see how much smaller the red cells are as compared to the white blood cells. The highest risk under 2 years of age and over 6 months of age. Those who are having heavy menses, eating disorders, and the other instances listed here. When should you start iron supplementation? Generally at 4 months of age in full-term infants, 1 month of age in preterm infants, and the oral supplements are listed here. And remember that the preterm infants may require 2 mg per kg per day as compared to term infants who require only 1 mg per kg per day. By 1 month of age, all preterm infants will be requiring that level, 2 mg per kg per day, and it should be continued until they're either weaned to iron-fortified formula or they reach 12 months of age. So remember vitamin D and remember iron in your patients as you're discussing this in regards to anticipatory guidance. All right, we're getting there. The answer on your board exam is no corporal punishment. Okay? That's definitely the answer on your boards. Timeout. Timeout by 9 months of age. That's what the books say, but I doubt that. But 1 minute per year of age up to a maximum of 5 minutes. So generally, timeout works pretty well in children up to about 5 or 6 years of age. And after that, the most effective form of discipline is really withdrawal of privileges. Keep it consistent, keep it brief, and it should be immediate. Wait till so-and-so gets home. You're going to be in big trouble once he or she hears what you did at 9 o'clock this morning. And that's not effective. That's not effective in terms of discipline. And with multiple family members in the household, this is a real problem because children are smart and they're going to quickly learn that grandpa is going to let them get away with something whereas mom doesn't, whereas dad might, and they just go from one family member to another. So consistent administration of immediate discipline by all family members is critical as you're talking with your patients during anticipatory guidance. So let's look at some common problems in general pediatrics. I think it's pretty clear cut now. In our emergency medicine lecture several days ago, we heard that the frequency of visits in terms of overdose of over-the-counter cough and cold medications is markedly decreased since the recommendations were put into place not to use cough and cold medications. Now, a couple things about otitis media. Know the risk factors for primary otitis media. Age-wise, lack of breastfeeding, exposure to secondhand smoke. I'm not sure that I have ever heard a parent say to me, "Yes, I smoke," in front of my child. Never. They always smoke outside, they always change their clothes, they always wash their hands, and then they come in. And I shouldn't be flippant about it, but it is a real problem. And you've been in rooms before where you can smell the smoke on the clothing. So it really behooves us to continually emphasize the importance of exposure to secondhand smoke. It's irritating to the eustachian tubes, leads to eustachian tube dysfunction. Genetic and anatomic predisposition, child with cleft lip, cleft palate, child with Down syndrome, child with any other craniofacial syndrome is going to be more likely to have frequent episodes of otitis media, as are younger children with older siblings and those who attend daycare. What about recurrent otitis media? These children are generally under 2. They've had multiple episodes, oftentimes before 6 months of age, and they've had frequent exposure to antibiotics. And that is certainly, that next to the last bullet is a reminder for all of us to be judicious in our use of antibiotics. So last year in Pediatrics, there was a very long article from Pittsburgh and other institutions that established newer guidelines for otitis media, which is defined as moderate to severe bulging of the tympanic membrane or the new onset of otorrhea that is not due to acute otitis externa. And it's pretty easy to determine whether acute otitis externa is present because pulling on the ear will generally cause significant pain if otitis media externa is present. Another definition is mild bulging of the tympanic membrane in association with the recent onset of symptoms. Difficulty sleeping, pulling on the ears, etc. Do not make the diagnosis of otitis media in children who do not have effusion based upon pneumatic otoscopy and or tympanometry. And I really would encourage you to use pneumatic otoscopy because you know as well as I do that a child who is crying is going to have a red ear. The vasculature is injected and the ear can look pretty red, but if it moves like a sail in the wind with pneumatic otoscopy, then you can be confident that there's not middle ear effusion. And I have no doubt that over the years I have overdiagnosed otitis media because I've been lazy about pneumatic otoscopy. And this is something that I think we need to emphasize for obvious reasons. Management should also include assessment of pain, which should obviously be treated. Now, if they're under 6 months of age, we're going to treat them, okay? If they're over 6 months of age, there are a couple of scenarios where observation may be indicated. What is described as severe unilateral or bilateral acute otitis media should be treated. What is severe in terms of symptoms is listed here. So not only do you have marked erythema and marked bulging, but the individual is affected by it from a symptomatic standpoint. Non-severe, which is described as milder ear pain and lower temperature. If it is bilateral, most individuals would prescribe antibiotic therapy. But the interesting recommendation in this is if it is unilateral, then that is an option for you to consider observation. And again, I think this is going to certainly be a judgment call on your part based on your level of comfort with the parents upon the child's particular history and the like. But this is a newer part of the recommendations that separates out bilateral versus unilateral, so-called non-severe disease. Whenever observation is used, it is very important to be sure the parents are reliable, the parents are easily contacted and can easily contact you. And this has kind of gone back and forth. Can we observe otitis in older children, or should we always treat it? Certainly in Europe, the diagnosis of otitis media oftentimes leads to pain control and call me if you're no better in 2 or 3 days. And the incidence of mastoiditis and bacterial complications, depending upon the study you read, is relatively similar to the incidence in the States where we tend to treat. And again, in older children, the option to observe is there. So just out of interest, how many of you are tending to observe older children with otitis media? And how's it gone? Do most of them get better in your experience over 2 or 3 days? Okay. I don't have a lot of experience with that, but the experience I do have, the majority seem to do okay. These are children who can tell you that they're feeling better. Again, these are reliable parents. And I've been pleasantly surprised at the lack of pushback that I've gotten from parents after a discussion about maybe we can watch this and see how they do for a couple of days. Now, amoxicillin remains the drug of choice for otitis media if that particular drug has not been used within the last month, and there's not associated purulent conjunctivitis. Remember, otitis conjunctivitis is a typical presentation of non-typable H flu, and that's why amoxicillin is not recommended in the presence of conjunctivitis and is not allergic to penicillin. Now, again, thanks to one of you that I talked to at the break, the question came up, okay, well, what do you do if they're allergic to penicillin? And so we looked it up because I wanted to make sure that these recommendations were up to date. If it is not an immediate reaction, you get a little rash in 5 days after amoxicillin, then go to a cephalosporin. If it is an immediate reaction, then your choices aren't that good. They talk about azithromycin or clarithromycin or clindamycin, but it is going to be more challenging and difficult to treat someone who is truly pen allergic from an immediate standpoint for otitis media, because azithromycin and clarithromycin are not nearly as effective in many individuals who have strep pneumo as the cause of their otitis. I should have mentioned, be familiar with the causes of otitis. Strep pneumo, non-typable H flu, Moraxella catarrhalis. And remember also that if you get a question about which one of the following diseases has not decreased in incidence since initiation of the Hib vaccine, it's going to be otitis, because invasive Hib is caused by Hib. So cellulitis, meningitis, bacteremia, all of those have been essentially eliminated because of the Hib vaccine. But H flu in the ears and in the sinuses is non-typable. And that's why the particular vaccine has not impacted in a positive way the frequency of H flu otitis media. Prescribe an antibiotic with additional beta-lactamase coverage for acute otitis if they have received amoxicillin recently, again, if they've had purulent conjunctivitis because of H flu. Okay. Why does it remain the drug of choice? Because it usually works. Again, there's some indication that we can perhaps begin to cut down on the use of high-dose amoxicillin to regular dose. But on your exam, the answer is high-dose amoxicillin. And the reason for that is high-dose amoxicillin, for lack of a better word, supersaturates the abnormal penicillin-binding protein. And remember that penicillin-binding proteins are altered by resistant pneumococcus. So you double the dose of amoxicillin, you get more amoxicillin on that abnormal binding site, and you're able to get enough of the drug into the organism to kill it. So there's no doubt that your exam answer should be high dose. That's true for sinusitis, for pneumonia, and for otitis media. But again, it works most of the time. It's cheap. It's safe, it tastes good, and it has a narrow spectrum in terms of activity. Why is it effective in so many cases? Well, it kills sensitive strep pneumo, it kills moderately resistant strep pneumo, but it doesn't touch MCAT because that's beta-lactamase producing, and it doesn't touch a lot of H flu because that's beta-lactamase producing. So why does amoxicillin apparently work in those cases? It works because almost all Moraxella otitis gets better on its own. And a good number of H flu otitis gets better on its own. So the fact that amoxicillin works in the majority of cases when strep pneumo is the cause, and the fact that there is spontaneous resolution of MCAT and H flu make the use of a cheap, effective, narrow-spectrum drug still enables us to recommend it. So many H flu, most MCAT, resolve spontaneously. So I'll get questions a lot from residents and students saying, well, why don't we just start with amoxicillin clavulinate? Or why don't we just start with ceftonor? The answer to that is on this slide. Plus, those are more broad-spectrum drugs associated with more side effects and, in some cases, not all cases, more expensive. Included in the treatment guidelines is a recommendation that prophylactic antibiotics not be used in regards to recurrent otitis media. And recurrent otitis media is generally defined as 3 episodes within 6 months or 4 episodes within a year. This does, however, give us the opportunity to emphasize to parents the importance of immunization, not only with pneumococcal conjugate vaccine, but with the flu vaccine. Because certainly bacterial meningitis is a relatively common complication of influenza. So parents can be encouraged that not only are they protecting them against the vaccine-specific disease, but they are protecting them against the possibilities of associated secondary complications. Again, encourage breastfeeding. Make sure that in that discussion you are encouraging mom not to lie flat while breastfeeding, and encourage avoidance of tobacco smoke for all the reasons that we talked about. Don't treat otitis media with effusion, which is defined as fullness of the tympanic membrane, sort of a bluish, whitish discoloration, clear rather than markedly erythematous. And you can see the air fluid bubbles here, and those air fluid bubbles mean that the eustachian tube is starting to work again. It's not working great, but it is starting to work again. And you tell parents most of the time this is going to resolve on its own in 2 or 3 months. And although it is a barrier to sound conduction, in general, unless it persists for more than 3 months, or if parents are describing language delay or difficulty hearing, then watchful waiting for otitis media with effusion is the way to go. So in the scenario that you are presented with, unless there are worrisome developmental or language issues, it's okay to say watchful waiting. Antihistamines and decongestants are ineffective. Corticosteroids have no long-term efficacy, and antibiotics are not indicated. Middle ear effusion that looks like the picture that I just showed is certainly not an excuse for us to use antibiotics. Now, you may have a tympanogram or two on your exam in the content specifications for the board. They do ask you to be able to interpret a tympanogram. So let's just look at a normal tympanogram. So what happens when you do a tympanogram? So here's the probe, and here's your ear. And you place the probe in the ear canal, and the first thing that it reports back to you is the volume of air in the external ear. And so what? Why is that important? Well, it is a wonderful way to answer 2 questions. Because if you have a patent tympanostomy tube, or if you have a hole in your eardrum, the external ear canal volume that is measured on the tympanogram will also include the middle ear volume, because you have a hole between the two. And so it will be 2 rather than 0.8, for example. So if you're like me and you've looked at a child and there's a tube there and you don't know whether the tube is in or not, you don't know whether it's patent or not, a tympanogram is a great way to safely assess whether that tube is patent or not. So if you're asked a question about why check external ear canal volume, what they are looking for is your knowledge of the fact that the external ear canal volume will be abnormal, in other words, too high, when there's a hole in the drum, either from a perforation or from a patent tube. And then the tympanogram asks this question: at what pressure does the tympanic membrane have maximum mobility? In other words, how much does the probe have to suck out a retracted tympanic membrane to the neutral position? Because a tympanic membrane has to be in the neutral position before it can have maximum mobility. So right here, I don't have to use any negative pressure because the tympanic membrane is where it should be. So I have maximum compliance at about zero pressure, which means the pressure in the middle ear is equal to atmospheric pressure, which means the eustachian tube is working properly. Now, what if the eustachian tube is not working properly? Now I'm going to create a vacuum. And here's my tympanic membrane. As a vacuum is created, because the eustachian tube is blocked, that tympanic membrane is going to be retracted more and more and more. And then, in order to get maximum mobility, I'm going to have to pull with negative pressure that tympanic membrane to the neutral position. And what that is a retracted drum. So the further negative the peak is, the more that tympanic membrane was retracted, and the more pressure had to be applied to that tympanic membrane to bring it to a neutral position. So this, I'm just going to answer this question, is an indication of eustachian tube dysfunction because the peak is not here where it should be, but it is very negative. So a relatively normal peak in a negative position means eustachian tube dysfunction, which has created a vacuum. And then over time, what happens? If you have a vacuum, that means you have no oxygen because all that oxygen has been built up. What happens when you have no oxygen? You have cell damage. Cell damage means secretion of fluid. Secretion of fluid means a great culture media for bacteria. So as you develop otitis, this curve will become progressively flatter until the point where it is completely flat. So if you are shown a tympanogram that basically goes like this, i.e. a flat tympanogram, that patient has acute otitis media unless their ear canal volume is too high, because a flat tympanogram will also result from a perforated drum or from a patent tympanostomy tube. So let's review. A flat tympanogram, acute otitis media, or a hole in the drum. A retracted tympanogram that has a nice peak to it, like this, means eustachian tube dysfunction, but no infection. And if I doubt they'll show you this, but if they show you a tympanic membrane that looks like this, it goes way, way up, in other words, it's super compliant, then that means that the ossicles are not working properly. They've been destroyed. They're not going to show you that, I don't think. But look for flat, look for retracted, and look for normal. It's eustachian tube dysfunction. Okay. All right. Vision problems. This is a little girl. Actually, this picture was taken. This little girl had rubella. I had another picture of they had back before the vaccine, they would have special classes for children with congenital rubella. And it was really sad. They had a group of, 20 or 25 children with their teacher, and all the children had huge glasses on, and they were squinting, and you could tell that they had some significant visual problems because of their congenital cataracts, because of their congenital rubella. And this little girl was in the same set of pictures that I was looking at as I prepared this. had congenital rubella as well. So as you're screening the eyes, look for strabismus, ESO, exo, hyper or hypotropia. And also remember, if this is acute and not chronic, remember that acute involvement of the sixth nerve can oftentimes be a major complication of bacterial meningitis, like we learned in one of the earlier talks. The reason it's important to identify strabismus is that it's associated with amblyopia and the loss of visual acuity in the malaligned eye. And more information about amblyopia is here. So the earlier the intervention, the more likely you are to preserve appropriate vision. All right, let's look at the head circumference for a second. So here's the normal skull, and there's going to be issues with head circumference, and it's important to keep in mind a couple of things. Here are your definitions of macro and microcephaly. 2.5% have macro, 2.5% have microcephaly. Again, kudos to those of you here who do indeed measure the head circumference 3 times, because that's what's recommended. And again, you are recommended to take the largest of the 3. Good idea to allow 24 months for catch-up growth in preemies. And remember that many preemies will tend to first allow for catch-up in their head, and you have to watch that carefully because preemies are also at increased risk for hydrocephalus, and the head circumference growth usually exceeds length and weight growth. So the head is the first to catch up, just like it's the first oftentimes or the last to lose, excuse me. And so beware of plotting head circumference in preterms because you may be missing a hydrocephalus. Primary and secondary microcephaly, they do differ. So primary by definition is genetic, and secondary by definition is secondary to an insult, be it a toxin, an infection, or trauma. So this would be an example where you have the head circumference measured over time. Things are going along about the same percentile, and then suddenly, as we talked about earlier, it starts dropping percentiles. Now, what can cause macrocephaly? Excess CSF, excess brain tissue, thickening of the skull. Probably the two most important things here are follow for hydrocephalus and always be suspicious of non-accidental trauma. Because certainly non-accidental trauma, especially with a subdural, that subdural may not present acutely like an epidural bleed would. Plagiocephaly is far, far more common now, as you're well aware, because of the Back to Sleep campaign, which has dramatically reduced the incidence of SIDS. It usually resolves as the child has more tummy time. I just don't like that word, tummy time. I don't know. It's got to be a better way. You know, give your child some tummy time. I said that to my son, who's got a 3-month-old. He looked at me like, what are you talking about? So if you have a better word, you know, abdominal rest, I don't know. But anyway, there'll be plagiocephaly for sure. One thing to remember about craniosynostosis is that's obviously something you're going to think about. If this head circumference is falling off, could this be craniosynostosis? Is that unless all of the sutures are involved, which is very unusual, the shape of the head is going to be abnormal. And the key thing to remember is that skull grows perpendicular to the suture line. So, for example, a premature closure of the sagittal suture will prevent growth perpendicular. And so scaphocephaly, which is the most common cause, or the most common type, I should say, of craniosynostosis, the head is misshapen in the form of a football, so to speak. So remember that skull growth occurs perpendicular to the suture line and leads to compensatory growth along the remaining open sutures. So there may be associated ocular problems, neurologic problems, increased intracranial pressure. Again, the sagittal suture, if you're asked, is the suture that most frequently is involved with premature closure. Remember also that if there are more than one sutures involved, it is oftentimes associated with a craniofacial syndrome. And the two most common craniofacial syndromes are listed here, Apert's and Crouzon's. And there are some differences between the two that you should be aware of, and they're listed on this handout. Remember also that craniosynostosis or premature closure, as you feel the child's head, you'll feel ridging in the area of the premature closure. And that ridging is very different than the molding that is very typical in a newborn. So molding is a step off because the skull's going like this, so you have that step off, whereas the ridging with craniosynostosis has sort of a mountain peak feel. And so they might describe in your question palpation of the suture lines indicates a ridge or indicates a step off. And a step off in a newborn is perfectly normal. Now, a step off in a 2-month-old is very abnormal because that indicates that there's no growth. But molding is going to feel different than craniosynostosis. And we've talked a lot about this already, but remember that the shape of the skull in primary craniosynostosis is going to be abnormal, whereas the shape of the skull in secondary or acquired microcephaly will typically be normal. And as you're reading a question, that's another seemingly innocuous piece of information that might actually be very helpful for you. Okay, so when the growth pattern, when is it prenatal? In general, birth weight, height, and head circumference will all be low, and importantly, they will continue to fall further away from population means on all of the growth parameters. Differential diagnosis is extensive, and some of the information may, for example, be offered to you in the vignette. So, APGAR scores of 3 and 4. For example, to tell you that there was significant hypoxia, mom hypertensive or using cocaine. A genetic abnormality will oftentimes be associated with all 3 parameters being low. So the typical growth pattern of a prenatal insult is outlined here. Now, what about a postnatal insult? Again, the early growth parameters are normal, then they will begin to fall off, and oftentimes they'll cross percentiles during the first couple of years of life. And this is more suggestive of a postnatal event. Probably, unfortunately, one of the most common examples of this would be shaken baby syndrome with associated injury to the central nervous system. What's the growth pattern in caloric insufficiency? So we looked at the growth pattern in a postnatal event. We looked at the growth pattern in a prenatal event. How about in caloric insufficiency? There will be significant weight loss or failure to thrive, but in this, the head circumference will be relatively normal. So if you're presented a scenario where the height is 7th percentile, the weight is 6th percentile, and the head circumference is 45th percentile, and there's no evidence to suggest that that's due to hydrocephalus, then that's a key that the caloric insufficiency may be causing this particular abnormal growth pattern. So let's look at Ben. He's an 8-year-old. Healthy, both parents are healthy. He's got a negative review of systems, no problems at birth, and grew right along the 25th and 50th percentiles for the first year or so of life. And then he gradually went down and is now at the 3rd percentile. He's been at the 3rd percentile for the last several years. And in fact, since age 5, he's been tracking at the 3rd percentile. So he was normal, and he crossed some percentiles, and then he found his own curve. Remember that. If you find your own curve, that's a big clue. Both parents are between the 25th and the 50th percentile. So what's the most likely diagnosis accounting for Ben's pattern of growth? Normal at birth, normal growth for the first couple of years, crossed some percentiles, and now has found his low percentile for the last 2 or 3 years. Great. Okay. So correct. Constitutional growth delay. So a very typical scenario of constitutional growth delay. So let's look at that a little bit more carefully, because there's no doubt on your boards you're going to have to differentiate constitutional growth delay from genetic short stature. So they have normal birth weight and length, drop off after growing reasonably well, and then the childhood growth curve parallels the lower percentiles, usually about the 5th percentile, and then they pick back up. So if you can kind of imagine a growth chart, here's the first 12 or 18 months, then we're dropping back down, and now we're around 4 or 5, and we're starting to follow a new curve. So the acquisition of a new curve should generally allow you to rule out an underlying organic etiology, because an organic etiology is going to continue to cause abnormal growth. And that's a key finding. So thinking about constitutional growth delay, what would a bone age tell you in a child? This is Ben. You think he has constitutional growth delay, and you want to prove it by getting a bone age. Will it be delayed, advanced, normal, or will there be no relationship at all? Great, good. Okay, so it will definitely be delayed in constitutional growth delay. All right. Be familiar with the term height age. You have chronological age, bone age, and height age. Chronological age is obviously how old you are. Bone age is how old your bones say you are. Height age is this. Height age is the age at which your current height is equal to the 50th percentile. The age at which your current height is equal to the 50th percentile. And in constitutional growth delay, oftentimes the bone age is close to, if not equivalent with, the height age. So bone age equals height age equals constitutional growth delay. Bone age equals chronological age equals genetic short stature. Okay? So a bone age is an incredibly valuable thing to get, and a very easy, non-invasive thing to get that will help you differentiate between genetic and constitutional growth delay. And the way that you figure out, well, how old is this person? Well, what is the height age? So let's say you have a 9-year-old, and that 9-year-old is in the 5th percentile on his growth chart. So you just take that point and you go back. And you go back until that point intersects the 50th percentile, say at 6.5. That's his height age. The age at which the current height equals the 50th percentile. And your bone age is going to be equivalent to your height age with constitutional growth delay. Okay, so here it is. Now, if your bone age is advanced, that's a whole other story. That's precocious puberty. That is a referral to endocrinologist. So know those three terms, and the easiest way to differentiate between genetic short stature and constitutional growth delay is to get a bone age, which is basically an X-ray of the left hand. All right. Failure to thrive. So it's a descriptive term with multiple definitions, and it's poor weight gain, and in severe cases, it is weight loss. Remember, it's the head circumference that suffers last. Okay? Length and height are affected earlier. The parameters affected depend upon the source of the problem, the severity of disorder, and the duration of the disorder. And again, the thing to keep in mind to begin with is that the head circumference is maintained as long as possible. So one of the hints that you may get in your scenario is a difference in the times at which the three parameters of growth have changed, with usually weight, then height, and then finally head circumference. Okay, so what's the definition? The definition clearly is usually poor weight gain, and it's only in the most severe cases that there is actual weight loss. Now, it is not ideal by any stretch of the imagination just to have one point in regards to growth. It is far better to have multiple points. But if you have only a single point, then these are the concerning findings on a growth chart. So weight under third percentile, weight for height under fifth percentile, etc. And then if you have a series of points, again, it's crossing two major percentile divisions that should prompt the most concern on your part. All right, so keep in mind that failure to thrive is rarely organic in etiology. And infants with short stature, so genetic short stature, or infants with constitutional growth delay should not be considered as having a failure to thrive for the reasons that were mentioned. And rarely will failure to thrive present alone. It will typically present with additional symptoms. And so for the test, these are the things you need to keep in mind in your scenario that should clue you into the fact that an organic etiology is more likely. Associated developmental delay, a positive review of systems. So for example, when we talked about Ben with constitutional growth delay, remember that in the scenario, Ben had a benign review of systems and was otherwise well, or if there's any abnormality on the exam. So more closely, let's look at the most common cause of failure to thrive. These are the sort of triggers that you might read in your exam question that should help you focus in on severe psychosocial failure to thrive, which unfortunately is the most common cause of failure to thrive. And again, unfortunately, many of you have seen this. You walk into a room of a hospitalized child, the child is laying there, child does not maintain eye contact, not particularly happy or upset to see you. If you talk to parents who have recently adopted a child from an orphanage, for example, they will oftentimes describe the apathetic withdrawal, the avoidance of eye contact, and these are major clues that the etiology of failure to thrive is likely not organic, but rather psychosocial. If it's organic, they might describe an extremely fussy child, or a child with other physical findings that we'll talk about in a second. Now, previously, when I trained, this was a rule-out diagnosis. So if a child with failure to thrive was hospitalized, then we would order test after test after test to try to figure out the etiology. And if we couldn't think of any more tests to order and everything was normal, then we made the diagnosis. And that was, in retrospect, terrible. Because it put the child through a lot. And I can honestly say that I hardly remember ever picking up an abnormality on those routine labs unless we sort of knew just based on the history that there would be an abnormality. So there are medical causes of failure to thrive that you're going to have to remember. And there are two classes. There's a caloric wasting and an increase in caloric requirements. So excessive caloric losses are usually GI or renal in origin, and excessive need for additional calories are usually cardiopulmonary in origin or associated with an underlying neoplasm or recurrent infection. And this may help you to sort through a particular case. Now, what do you need to look for in your scenario on your exam question that might clue you into the fact that this is a organic rather than a non-organic cause of failure to thrive? So the demeanor, apathetic, disinterested, that can go along with psychosocial failure to thrive. What does not go along with it is voracious. And the voracious feeder is a typical description of a child with pyloric stenosis, the so-called hungry spitter. Most people don't want to eat right after vomiting. Children with pyloric stenosis surely do want to eat after vomiting. How is the formula mixed? How much is fed? Unfortunately, we all probably have seen a child whose formula is being diluted for economic reasons. It's the end of the month, formula has run out, well-meaning parent dilutes the formula until he or she can get additional formula. So that might be the scenario that surrounds a hyponatremic seizure, for example. Is mom's breast milk in? Does mom hear the baby swallowing? Does the breast empty or her breast full in the beginning of the feeding and feel significantly less full at the end? Recurrent vomiting and or diarrhea does usually not accompany non-organic failure to thrive and is a big clue in regards to vomiting to underlying metabolic disease and in regards to diarrhea, underlying chronic GI disease, such as celiac disease or inflammatory bowel disease. And then the nature of the stools. If they float, if they're bloody, if they're foul-smelling, all of that is suggestive of a malabsorptive disease. CF or Schwachman-Diamond are probably the two that are going to be most commonly discussed. And then tiring with feeds. Remember, the most work a baby does is to eat. So if a baby is experiencing angina because of a coronary artery anomaly, that baby will sweat and that baby will cry and that baby will tire when feeding. So tiring with feedings would be another key buzzword to keep in mind. And then if there's symptoms of hypothyroidism or symptoms that could be suggestive of diabetes or SIADH or DI, the latter two indicating an underlying central nervous system problem. What about your physical exam? What might be presented to you on your question that should help you decide that maybe this is not psychosocial? So dysmorphic features, murmurs, abdominal distension or flank masses, abdominal distension, oftentimes associated with malabsorption, again, celiac disease, flank masses, Wilms, or neuroblastoma. Congenital infection. Again, we talked about cataracts, rash, hepatosplenomegaly. One would not expect these to occur in non-organic failure to thrive. Wasting of subcutaneous tissue, lateral buttocks is a huge hint for a malabsorptive disorder, again, usually celiac disease. And then difficulty with feeding from an anatomical standpoint. And evidence of hypothyroidism. Remember that hypothyroidism is the most common cause of prolonged neonatal jaundice, and it also is associated with an umbilical hernia. And so those findings may be key. So slightly jaundiced 4-week-old with a large umbilical hernia whose mom comes in saying he's not stooled for 3 or 4 days. There's going to be enough information in your scenario to help you to realize that you've got to do some additional workup. And then obviously persistence of newborn reflexes and abnormalities of tone. So who should be hospitalized? For the most part, it's pretty straightforward. If you think the child obviously is any danger, they should be hospitalized. Severe malnutrition, medically unstable, or failure of outpatient management. Once we got a little bit smarter during my residency, we began to hospitalize children with failure to thrive, and we did nothing for 3 or 4 days while we watched them eat. That was back in the days where you could hospitalize someone for 3 or 4 days just to eat. Unfortunately, you can't do that anymore. But failure of outpatient management was, from that perspective, very helpful. Developmental delay, keep in mind that preemies, if you're not correcting for their gestational age, will sometimes appear to be developmentally delayed when they are not. And also, as you're working through developmental delay and failure to thrive, be sure that there are not obvious reasons for the presenting symptoms like we've talked about in terms of hearing, vision, neurologic problems, and the like. So how do you evaluate children for developmental delay? We're moving away from failure to thrive and into developmental delays. And obviously, you need to take a history, physical exam, complete review of systems, and the like. And laboratory testing, just like with failure to thrive, should be guided by the historical and physical information that you're given in your vignette. Consider a newborn metabolic screen. Check to make sure that it's normal. When applicable, lead level, thyroid studies, genetic testing. This is a typical picture of a profoundly hypothyroid child. Notice the umbilical hernia and some evidence of yellowish skin. So I just put this together. Again, I would just perhaps put this in along with some of the last few slides on your metabolic lecture, just some things that should make you think of underlying metabolic problems associated with developmental delay. And so, for example, I mentioned this earlier, but a key hint, E. coli sepsis with galactosemia, especially if there's cataracts, the various odors associated with certain disorders, the fact that urea cycle disorders are always associated with seizures and hyperammonemia. So I would suggest that, again, this slide really be kind of moved over into the summary slides for your metabolic talk. There was a really, really nice box that you were provided that looked at glucose and ketones, for example, and I think this would help, at least I hope it would help supplement that. When should you image the head? It's pretty straightforward. We talked a lot, for example, about neurocutaneous abnormalities, NF, Sturge-Weber, tuberous sclerosis. And so these are pretty straightforward in terms of when imaging of the head in children with developmental delay might be indicated. A couple of quick things, and then we're going to take about 20 to 25 minutes to go through all the high-yield orthopedic issues that you may see on your exam. One thing to keep in mind is the difference between breath-holding spells. There are two types of breath-holding spells, and either type of breath-holding spells, the presentation may be such that they're going to want you to order an EEG, and you don't want to order an EEG. A breath-holding spell is an opportunity for you to reassure, and this is one example of where reassurance is going to be the correct answer. A cyanotic breath-holding spell is a child who just isn't happy. No, you can't have another cookie. I need that toy. We need to leave. The child cries, 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 holds his breath, and holds his breath, and becomes cyanotic. We've all seen it. Okay? That's a so-called cyanotic breath-holding spell, usually pretty easy to differentiate from a seizure. What is sometimes less easy to differentiate from a seizure is a pallid breath-holding spell. Well demonstrated. You must think my boys are pretty active, but this was about 4. This is my younger child. I was in the front yard. He was flying a kite in the backyard. I heard him hit the tree because he was looking this way as he flew. And so when I got there, he was pale, and I wasn't sure he was breathing. And I even thought I saw his eyes jerking. So I just took a big breath, and I think I about passed out. I was going to try to say, well, I just said it was a pallid breath-holding spell. No, I actually had to, I had a pallid breath-holding spell myself. But he was okay. But a pallid breath-holding spell is you get hurt and you stop breathing. So there's no cry, 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 stop breathing. You get hurt and you stop breathing. And these are the ones that are sometimes associated with a brief period of tonic-clonic activity. But it's the history that you will be given that will allow you to say no workup as necessary. So know the difference between temper tantrums and breath-holding spells. Again, syncope may occur. There may be a brief period of time before spontaneous respirations return. Tonic-clonic movements may occur. Again, all 3 of those bullets, much, much more common with pallid rather than cyanotic breath-holding spells. Sleep problems, just put the child down when they're awake. That's the bottom line. As nice as it is to rock your children to sleep, if you put them to bed while they're asleep and then they wake up, it's going to cause much more difficulty in terms of sleep issues. So that's the one thing that you're going to want to look for as an option to say yes to, and to do your best to avoid any nocturnal feedings any later than 6 months. Discourage co-sleeping, and remember the importance of not only back to sleep, but remember the importance of absence of anything in the crib. And we've got pictures of our children. We have 4 children. We've got pictures of them in the crib. You can hardly see them. They're on their stomach. There's multiple toys and this and that. It's really scary. That's what it was okay back then. And to this day, I still have a little trouble putting my grandchildren into bed on their backs with kind of just nothing in there. But that's certainly very, very important to talk about with your parents. Routine for toddlers and preschoolers. And it's so easy to say attempts to not sleep should be met with a gentle but firm, no, it's bedtime. Again, much more difficult sometimes in a real world. And then know the difference between a nightmare and a night terror. Nightmares are disturbing dreams, usually during REM sleep, followed by awakening in distress, peaking at 3 to 5 years of age. By definition, the child remembers everything. I had a bad dream last night. There were monsters under my bed. Okay? A nightmare can be treated just with reassurance, maybe talking about it the next day. A night terror occurs in non-REM sleep. The child looks extraordinarily frightened, but you can't wake them up. And these may last anywhere from 5 to 15 to 20 minutes. If they tell you that the patient is sweating profusely, that's going to be a night terror. The pupils are dilated and they're unconsolable and they cannot remember the incident. So know the difference between night terrors and nightmares. Know also that sleepwalking may accompany either, and the treatment for sleepwalking is safety. Habits you might be asked about. Intervention is basically ignoring it and redirecting it. Minimizing your reaction. And that's true of any nature of discipline. If an individual is doing something right, don't forget to compliment them. And if an individual is doing something wrong, oftentimes just distraction, moving them to a different level of interest is all that is needed. Specific measures may help depending on the habit. For example, I think, putting a nasty tasting liquid on the nails to stop nail biting is calling far too much attention to the problem, and I would just let it be, but parents may ask you about that. Parents are always going to ask you about thumb sucking. And the thing to keep in mind about thumb sucking, and the answer to the question is referral to dentist is not indicated until they're at least 4 years of age. And that's the age at which there may need to be some intervention in order to prevent malocclusion. What's colic and what isn't? It's important to know how much crying is too much and how much crying is normal. But you can see here that a 2-week-old cries about 2 hours each day, and that increases more and more. And as you well know, crying is more common in the evening hours. So what are the characteristics of colics? They're prolonged, paroxysmal, and refractory, begin and end without warning, unexplained, unrelated to the environment, invariably a little bit worse in the evening when people are getting home from work. Dinner is trying to be cooked, and the like. Now, these are the rule of threes, and you should probably know this, not really because they're going to ask you about what are the signs and symptoms of colic, but what they might describe to you as someone who does not have colic, and so these particular criteria will not be met. So it will be in the wrong age group, or it will be with an incorrect frequency and the like. So know the normal so you can recognize the abnormal that is presented on your exam question. Most colic improves by 4 months of age, and the treatment is basically reassurance. There's lots of options out there to choose, sugar solutions, simethicone, etc. And you'll certainly have parents tell you that some of these work individually, whether that's placebo or happenstance or whether it really works is a little bit of a debate. But your board answer, again, is a reassurance without any particular intervention. But you do need to know what's not colic. So age of onset greater than 4 months. Remember that colic might present, or a colic-like symptoms might present either with a corneal abrasion or a hair tourniquet, either around the digit or the penis. And know also that if the bouts are not daily or near daily, rather they're presenting with an acute episode rather than a more chronic episode, the crying started in the 3rd month or later, or there was a recent change in intake, this is less likely to be colic. Other things, abdominal swelling, bilious vomiting, both of those things obviously could go along with an obstruction. Systemic symptoms such as fever, obviously not going to be colic. So know the characteristics of colic so you can sort through, because the reason I took some time with this is colic is always going to be an optional answer in many scenarios that talk about fussy children. Recurrent abdominal pain, again, you should know that this is very, very common, usually in young school age into middle school age, peaking at the incidence of 7 to 10. If the description of the pain in your question is described as periumbilical, remember that that is a typical location for chronic recurrent abdominal pain, and there is some validity to the statement that the closer to the umbilicus the pain is, the less likely it is to be organic in etiology. So look for the location of the pain as the opportunity for you to determine whether or not the pain is organic or not in etiology. Oftentimes, recurrent abdominal pain is associated with environmental stresses, such as school, sports, social, etc., and there may be secondary gain. Recent divorce in the family, child doesn't want to leave mom at home, has a stomach ache, can stay home and make sure that mom's okay. Relatively common scenario. Same thing with, for example, the death of a sibling. Functional abdominal pain is the most common cause of abdominal pain in children and adolescents. So again, we're trying to sort out what's organic and what's not, just like we did with failure to thrive, what's organic and what's not. It's typically associated with a physical exam that is normal, and it is typically thought very much like a headache to be a functional disorder. Recurrent abdominal pain of organic etiology is only about 5% of children who have recurrent abdominal pain. So what do you need to look for in your scenario that should suggest that this is organic in etiology? So stool history, cholelithiasis, inflammatory bowel disease. So what might you hear with inflammatory bowel disease? Systemic symptoms, fever, rash, arthralgia. Cholelithiasis, probably some right upper quadrant pain, or maybe it's a child with sickle cell disease or spherocytosis. Celiac disease, abdominal distension, lateral muscle wasting, pregnancy, breast tenderness, nausea, PID, lower abdominal pain, low-grade fever, pain on cervical motion during pelvic exam, UTI, obviously dysuria, lactase deficiency, giardia. So the possibilities here, all of which can cause recurrent abdominal pain, will always in your question include some information as to associated systemic symptoms. And the absence of associated systemic symptoms should lead you to make a decision not to intervene any further in regards to workup. Worrisome bits of history that you might read: pain that awakens you at night, again, systemic symptoms, change in growth, bilious vomiting, heme-positive stool, CVA tenderness, mouth ulcers, perianal tags, fissures, again, Crohn's disease, and inflammatory bowel disease. Just a little bit about ADHD. I would say that you should know the diagnostic criteria. The onset must begin before 7 years of age, and the symptoms and signs persist for 6 months or longer. Now, this is not to say that ADHD should always be diagnosed before 7 years of age. Obviously, that's incorrect. But in going back and taking a history, the history that you're going to want to be a little bit wary of is things were just fine from a behavioral standpoint until he was 11. That's going to be less likely to be ADD or ADHD unless, in retrospect, you get the sense from the history that, yes, this has been a problem since 5 or 6, but he's now no longer able to compensate for those particular issues. So know the criteria for inattentive ADD. 6 of these 9 must be present. And along the same lines, know the criteria for ADHD. Again, 6 of the 9 must be present. I know you're familiar with these, but I do think it would be worthwhile to commit these to memory prior to the exam. So what's the lab workup for ADHD? Nothing. Nothing, and almost always nothing. Okay, so check their hearing and vision, obviously. I think it would be extraordinarily unusual to have an elevated lead level, but it's something you should think about. Thyroid function testing. I was telling one of you all at one of the breaks that I don't know how many thyroid functions I have ordered over the years, and I can honestly tell you that they've always been normal, with one exception that I'll never forget. And the mom's chief complaint was that he just keeps getting fatter, but every time I go to the store, I've got to get a bigger waist, but he's not growing. And the child just looking at him was obviously hypothyroid. So I think it's one of these tests that we get a lot. We suggest that you get it a lot, but you really have to look at the clinical scenario. So I think a random thyroid function test in a child with ADHD would have extremely low yield. One of the things to remember is that ADHD, and especially inattentive ADD, can mask a petit mal or absence seizure disorder. So if there is any indication in the history, multiple times she just doesn't seem to be there. A teacher says she'll call on her, and one time she answers right away and she knows it, and the next time she just looks like she's in outer space. Remember that could be an absence seizure. And as was mentioned a couple days ago, these can be brought on by hyperventilation, so that's when the pinwheel comes in, and having them hyperventilate, and you might see them as, I think I just had a petit mal seizure. So it's just a 2 or 3 second pause, and then you're right back on task, okay? Okay, that was my third, and then we're done. So you know what a petit mal seizure is. All right, multidisciplinary. Let me say one other thing. Petit mal seizures. Remember yesterday or the day before you saw an EEG, and it was 3 per second spikes, okay? If I see an EEG on an exam, I'm going to be terrified. I'm going to, oh my gosh, an EEG. I can only imagine them showing you one of 2 EEGs. Petit mal, 3 per second spike, or infantile spasms. Just a crazy, crazy pattern, and that's going to be the child with the ash leaf spot who seizes as a child and has infantile spasms. Outside of infantile spasms and petit mal seizures, I think you're good with EEGs. At least I hope. Treatment is multidisciplinary, positive reinforcement, extinction techniques, timeout for extreme behaviors, and know that the majority of patients do benefit from judicious use of medications. I'm not sure what is more overprescribed, an antibiotic or a stimulant, but we really need to be careful about how we use these medications. And oftentimes, the underlying etiology of the child's struggle is a comorbid disorder. So be very familiar with the fact that the comorbid disorders associated with ADHD and ADD are very, very common. Side effects of stimulant medications: headache, appetite suppression, insomnia, little bit of an increase in blood pressure and heart rate. Important for your boards, they do not cause tics. They may exacerbate an underlying tic disorder, and a tic disorder is not a contraindication to stimulant use. And in fact, some children's tics improve with stimulants because of the improvement in their ADD symptoms. They're called out less, they get more confident in themselves, they're doing better, and they're less stressed. And we all know that stress tends to make tics worse. So from a board perspective, you do not have to avoid stimulant medications in individuals with tic disorders. More concerning, but far less common are significant changes in mood or worsening of signs and symptoms associated with the ADD. And remember that the black box warning with stimulants, serious cardiovascular events, including sudden death in patients, and here's the key, pre-existing structural cardiac abnormalities. So certainly absolutely contraindicated in anyone with a structural cardiac abnormality. So not contraindicated in tics, definitely contraindicated in individuals with structural cardiac abnormalities. The AAP does not recommend screening EEGs unless findings on the history or physical exam are suggestive of heart disease. There was a very brief period of time when the Academy recommended that all children prior to starting stimulants get EEGs. And that went away very, very quickly because it was just simply impossible to do from a practical standpoint. Okay, child abuse. It's very sad that we have to even include this, but up to 1,500 deaths each year, and up to 5% of all children have experienced some sort of abuse. Child abuse is the second leading cause of death in children in certain age groups, only behind accidents. And some so-called accidents may actually be child abuse. Some SIDS may be child abuse as well. So, behavior. These are, again, pretty understandable and pretty expected. Disturbance in sleep, appetite, regression, aggressive behavior, and modeling behavior. Inappropriate interactions with inanimate objects, excessive masturbation, mimicking sexual acts with dolls, and the like. Usually the abuse occurs at home. The abuser is usually a trusted individual, and by definition, an STI in a child is secondary to sexual abuse. And there are three categories of risk. There are certain factors that are related to the child, to the abuser, and to the environment. So those children who have an underlying chronic illness or developmental delay or intellectual disability may be at increased risk of abuse because, I'm sure in large part, because they are oftentimes challenging to care for. What about, and don't forget stepchildren and adopted children are statistically at increased risk. What about the abuser? The abuser, him or herself, it's usually him, has oftentimes been abused himself. With little social support, poor family situation, oftentimes young, oftentimes multiple children, and again, a step parent would be associated with an increased risk of abuse. And because of that, some of the reason that step-parents are sometimes more likely to be the abuser is they lack an emotional connection to the child. Some studies, going back to the subsequent slide, also report higher incidence of abuse in children who have spent extended periods of time in the neonatal intensive care unit. Again, because many come home, unfortunately, with chronic disabilities, and the opportunities to bond have been adversely affected by the prolonged hospitalization, and certainly substance abuse. So the patient's history, red flags. So in your scenario that's being described, this child presents to the emergency department with such and such. Delay in seeking treatment, inconsistent history with physical findings. So one of the reasons you need to know your developmental milestones is they will give you a scenario that doesn't make sense developmentally. Big red flag for child abuse. So the typical one that we always use is 4-week-old presents to the emergency department with seizures. Parents state they found him seizing after he rolled off the bed. Okay, so a developmentally inappropriate chief complaint, huge red flag. Talk to mom, talk to dad, talk to grandma, you get 3 different histories. Inconsistent history, the physical findings are inconsistent, and the history is inconsistent with developmental stage. Burns that are patterned, circular, or stocking glove in appearance. Stocking glove, for example, a child is picked up and put into a bathtub with hot water, and immediately the feet go up, and there's a very clear demarcation, like the socks, or the buttocks, because the buttocks is submerged. Location of skin lesions, those that are more likely to be accidental versus those that are more likely to be inflicted, are listed here. So pay attention to the description of the injury in terms of location. Multiple stages of healing would be a clue that it is non-accidental trauma. And again, the particular pattern characteristics as well as the location. Injuries in non-walkers. Any type of head injury should have a very high suspicion of child abuse, and any fracture in someone who is non-ambulatory. Injury of the skin, high index of suspicion, as well as skull fractures, long bone fractures, posterior rib fractures, and bucket handle fractures. We'll look at examples of all these in just a second. Shaken baby, a violent shaking in a newborn who lacks head control. In some areas, the most common type of non-accidental that is seen. And the constellation of symptoms are retinal hemorrhages, intracranial hemorrhage, but once you see the CT or you see the chest x-ray, surprisingly little evidence of external trauma. And the outcome is extraordinarily poor, with long-term morbidity approaching 90%. All right, so what do some of these things look like? If you look at this chest x-ray, note that it is rotated. Okay, so see the child's rotated, so the ribs on the child's left are considerably longer than the ribs on the child's right, and the heart is completely rotated to the child's left. So if you, on an exam, have a poor film, i.e. a rotated film, they're not going to put a poor technique film on your exam unless there's a reason for that poor technique. And the reason here to give you a rotated film is to allow better visualization of fractures at various stages of healing. So you can see a relatively more recent fracture here versus a good bit of periosteal formation here, indicating a older fracture. And posterior rib fractures, because of the child being held so firmly while he or she is shaken, can result, or the posterior rib fractures from a direct blow. So posterior rib fractures for your boards are pathognomonic for child abuse. Subdural hematoma, large hematoma with a significant shift of the ventricles. Retinal hemorrhages, and oftentimes these retinal hemorrhages are even more extensive, and you may see evidence of a blurry disc indicative of papilledema. Spiral fractures, again, a long bone fracture in a non-ambulatory child. So keep all of those things in mind. And I didn't have a picture of a bucket handle fracture, but envision a long bone, and the end of that bone is avulsed, except it's hanging on the medial side and the lateral side. So it will look like the bucket handle, and it will be connected to the long bone like that. And that's from yanking. Okay. So there's a lot of orthopedics, and this is the time to look at some orthopedics. Benign limb pain, growing pains, peak at 8 to 12 years of age, most common musculoskeletal problem of children, unknown cause, and this will always be a choice. They may show you a picture, for example, of an osteosarcoma, and one of your choices would be benign or growing pain. So you need to know the characteristics of it in order to help you differentiate between what is worrisome limb pain and what is limb pain that is relatively unworsening. So here is a long-term or a pretty lengthy differential diagnosis, and we're going to go through these and look at them in a little bit more detail. And what I've tried to do here is to think through the most common orthopedic problems that are likely to show up on your exam. So a toddler's fracture is just what it is. It's a minimally displaced spiral fracture, usually of the tibia. So present with limp and bone pain. Sometimes they're very difficult to see, very, very different from the spiral fracture that we saw a couple of minutes ago. Osteoid osteoma. The boards love this question. Okay. Here's the clue. Wakes up at night. Never a good history to hear. Wakes up at night. This child may have a neoplasm. They will tell you this: pain does not improve with acetaminophen, but it gets a whole lot better with salicylates or nonsteroidal anti-inflammatories. And the picture of the osteoid osteoma is a well-demarcated area with sclerotic borders, usually within the shaft of a bone. But the characteristic improvement with salicylates and nonsteroidals and not acetaminophen is oftentimes the key in your vignette that will help you for an osteoid osteoma. Osteoid osteoma is one of 3 common cancer lookalikes. What are the other 2? Number 1 is an osteochondroma, and that will be described as a hard, painless bump, incidentally discovered during showering or getting dressed. And it's just what it feels like. It's a hard, painless bump. And on X-ray, you can actually just see the calcified area kind of sitting there. The other is a hard, painful bump. And what they will tell you there, it was an area of trauma. Got hit by a hockey puck, got hit by a fastball. And that is the trauma, say right here, causes deposition of bone into the muscle, which calcifies. Myositis, inflammation of the muscle, ossificans, bone in the muscle. The difference in history is that an osteochondroma is painless and bumpy. Myositis ossificans is painful and bumpy. Osteochondroma incidental finding, myositis ossificans preceded by trauma. Osteoid osteoma wakes you up at night, gets better when I take some aspirin. All 3 of those you may see in a scenario when they are trying to get you to differentiate between cancer and cancer lookalikes. Here's Ewing's, and Ewing's is sometimes described as onion peel. You can see here there's a bit of periosteum right there. You can see the bright sclerotic border of the involved periosteum and the starburst appearance of osteosarcoma. Now, certainly both of these will wake you up at night. Neither will get better with symptomatic treatment, unlike an osteoid osteoma, and neither will you be able to palpate, unlike the other two cancer lookalikes that I mentioned. Okay, so what if you have a limp in a toddler? Most common diagnosis, transient synovitis. The old term, which is a bad term, is toxic synovitis, because these children are not toxic. So this is a child who has a little bit of a hemarthrosis. So they jumped off the monkey bars, they jumped off a swing, and they come in either refusing to walk or limping, but they are non-toxic. You may see a little bit of an effusion on an ultrasound, but nothing else. That should be compared to the toxic child who is limping, because that's going to be septic arthritis. So when you have a particular child who comes in who is a toddler, who is limping, and that limp is, in terms of etiology, in the hip, the differential is transient synovitis versus septic arthritis, and the difference in the latter is you have leukocytosis, high sed rate, fever, and toxicity. But the chief complaint will be the same. She won't walk. And oftentimes they'll try to get you to work up a transient synovitis. Get a film or tap the joint. That's not going to be necessary in a child who is otherwise completely well and has normal long bone films, for example. Remember also, because we're kind of going to go through differential diagnosis of a limp over the next couple of minutes, hip pain does not present as hip pain. It presents as thigh pain, knee pain, groin pain. So in a scenario that describes lateral thigh pain, that's probably going to be indicative of hip pathology. Joint aspiration is the gold standard if septic arthritis is included in the differential diagnosis. And probably the bug that you get out is going to be Staph aureus, except if the child has sickle cell disease and has some osteo along with it, and that's going to be Salmonella. Okay? So septic arthritis, again, C-reactive protein, sed rate, elevated white count versus the otherwise healthy child who just plain doesn't want to walk. I think we did nursemaid's elbow and another, so I'm going to go through this real quickly. But just think of the child who's having a temper tantrum at the store and mom or dad yanks them up or they're swinging them around. I remember I was on moonlighting when I first started after my residency, and I was moonlighting on Halloween. I had 2 nursemaids' elbows. And it was the same scenario in both. The child started to run out in the street, and the parents grabbed them to bring them back in. So the history is a sudden pull, or the history is they found him in the crib not moving his arm. That means it was entrapped when he rolled over. Or the history is he was wrestling with his sibling. Arm is held like this, and the child doesn't want you to move it. And again, the annular ligament is partially torn. As the radial head moves distally, the ligament comes on up and gets entrapped. So it sort of looks like the child has herb palsy, except it's acute. So I think of this sometime as the acute herb palsy like appearance. But the history is going to be what gives it away. And there's an outline here. There's the ligament that has been entrapped. And as the radial head is pulled outward and then snaps back, that portion is trapped. Clavicular fractures you can pretty well pick up by crepitus. That will be the description that you're given, is there will be crepitance over the shoulder, say in a newborn, or crepitance after trauma. If they give you a history of crepitance over the shoulder in the newborn, that's probably a huge hint for a brachial plexus injury, or it's a huge hint for a pneumothorax. So beware of those 2 findings in the newborn, and that may be what they are helping you with. no treatment for a fractured clavicle. Congenital torticollis, etiology is unclear, usually appears several weeks after birth. The risk factors are breech presentation or shoulder dystocia. And so shoulder dystocia is a risk factor for brachial plexus injury. Shoulder dystocia, a risk factor for congenital torticollis. And also it is a risk factor for a fractured clavicle and pneumothorax. And that's simply because once the head is delivered, you're trying to bring that shoulder up over the pelvic rim and you're stretching the neck. And remember that this sometimes may be described as a mass within the sternomastoid. And that mass is basically blood that is now beginning to calcify. And as it calcifies, it causes torticollis. Remember also that the acute onset of torticollis is something totally different and may be associated with a neuroblastoma because of its location within the sympathetic chain. Also, acute torticollis in a febrile child is a retropharyngeal abscess. Okay? So acute torticollis, think neuroblastoma, think retropharyngeal abscess, chronic or congenital birth injury. And I think we just talked about that. And remember also that torticollis may sometimes be associated with cervical spine abnormalities. In the genetics talk, Klippel-Feil syndrome was mentioned. And so I just wanted to do that for completeness' sake. All right, stretching and physical therapy unless there's an etiology on an acute basis. All right, so a 3-day-old male has a significant left hip click during abduction. The right hip and the remainder of the exam are normal. Family history is negative for hip dysplasia. Prenatal and delivery histories are unremarkable, and the presentation was not breech. Left hip click. Which of the following is the best choice for the management of this finding? Triple diaper for a month and re-examine, consult orthopedics, get an x-ray, get an ultrasound, no imaging studies or treatment now, re-examine in a couple of weeks. Left hip click, nothing else. Good. Okay. So what's a click and what's a clunk? It makes a big difference. Let's talk a little bit about developmental dysplasia of the hip. Up to 1.5% of all neonates, and it's a disruption in the contact between the acetabulum and the femoral head. And without that contact, there's going to be very poor development of the femoral head. So you have two signs. You can take the femur and bring the hip out and bring the hip in. So the way I try to remember this is, femur, acetabulum, and now I'm doing my maneuvers, and I am able to bring the femur up over the ridge of the acetabulum, clunking it out. And then I'm able to bring the femur back in and clunk it back in. And you've felt dislocated hips, and every time I feel one, I go, oh my goodness, I've done something wrong to the child. It doesn't feel good. Okay? Now a click is ligament laxity due to maternal estrogen. So here's my femur again, here's the acetabulum. I am moving the femur, but it is not clunking out and clunking back in, but I can feel those clicking sensations. So that's a click, and you can actually feel them. Sometimes you can hear them, but you don't have that sudden give that is so typical of a clunk. So what was described in the scenario for this question was a benign click again, likely due to maternal estrogen. So you can bring the hip out, so-called Barlow or sign of exit, or sign of relocation, the ortolani, or bring it back in, and you hear the clunks in both. Screen in the newborn nursery and with every visit until a year of age. Now, important to keep in mind that limited abduction, asymmetry in the height of the knees, and asymmetry of the gluteal folds is very important, because what happens back to the femur and acetabulum is once it is dislocated, it usually is either dislocated also a little bit up or a little bit down. That's what makes leg length discrepancy, asymmetric height of the knees, and asymmetric skin folds. Okay? And the asymmetric skin folds, asymmetric height of the knees are really the most likely things to find outside of the newborn period. Because what happens is as that maternal estrogen decreases, I'm no longer able to clunk it back in and clunk it back out and clunk it back in and clunk it back out, because everything is tightened up. That's why clicks go away after 2 or 3 weeks. So every time I try to abduct the hip, I hit up against the side of the acetabulum, and I can't abduct it. So our youngest daughter was diagnosed by my wife at about 5 weeks of age with congenital hip dysplasia. When she called me, I'll never forget it, she said, something's wrong with Sarah. I can't change her diaper without her crying. Every time I try to clean her, I just can't move her hip. And she was telling me she had limited abduction. So it's not always picked up in the newborn period, and we're all so familiar with the clunk that we forget that there are other findings that you might be tested on. And those findings are asymmetry in the height of the knees, in the skin folds, and also limited abduction. So don't forget about those things. So clicks are benign. They resolve after 2 or 3 weeks, and they're likely the result of maternal estrogen. Who's at risk of developmental dysplasia of the hip? Young females, positive family history in a parent, positive family history in a sibling, breech presentation, and minor criteria for risk factors are listed here. So it's the female with a family history, breech presentation that is a combination of all the most significant risk factors. So you should screen all newborns. These are the AAP recommendations. If negative, think about the risk factors. If positive, refer to an orthopedist. Imaging and triple diapering are not recommended. If equivocal, repeat the exam in a couple of weeks. If positive at 2 weeks, refer to an orthopedist. If still equivocal, consider an ultrasound. My personal bias is if I'm not sure by the end of 2 weeks, I'm not going to wait anymore, because this is something you certainly don't want to miss. So just like yesterday when we were talking about testicular torsion, that's something I'm going to over-refer for. I am going to over-refer for congenital dislocated hips. But these are the specific recommendations that are updated by the AAP. Because you don't want these things to happen. You don't want hip instability, abnormal development of the femoral head. If they ask you what test to get, ultrasound is the preferred modality early on. And then later during the first year of life, you can go ahead and get an x-ray. So if they give you a scenario of newborn and you're definitely are given the characteristics of a clunk, x-ray is the wrong choice, ultrasound is the right choice. So this is what an x-ray would look like. You can see here that there's very little formation of the femoral head. And notice here, notice the position of the femur. It's a little bit towards the head, and it's more lateral. So again, you're going to have leg length discrepancy and asymmetry in the areas that we talked about. and they wear one of these things. That little baby, it just doesn't look right. Oh. It's like, sure, put it on. I don't mind. All right. So that we talked about limping in a 2-year-old. How about a 7 or an 8-year-old who limps? Okay. This is a classic question. So this is a 7-year-old who comes in and, for the last 3 or 4 weeks, I've been limping a little, my thigh hurts or my knee hurts. It's a characteristic presentation of leg Café-Perthes disease. Important word, idiopathic, because you can also get avascular necrosis of the femoral head for worrisome reasons. Sickle cell disease and long-term corticosteroid therapy are probably the two you're going to be asked about. So avascular necrosis of the femoral head for idiopathic reasons is termed leg Perthes disease. But if you can come up with a reason, then leg Perthes disease should not be used. You can see the ratty appearance of the femoral head. Again, this is usually pre-adolescent, typically unilateral, a little bit more common in boys. And because limping is painful and because you're trying to limp all day, it tends to be worse at the end of the day. As nasty as it looks, the treatment is mobilization, rest, and NSAIDs, and most of the time you get better without surgery. That's, you can see here again an imaging, and you can see the descriptions here, and know also that you're certainly going to pick up changes earlier on with scans than you will with plain films, but on your boards, they're going to give you plain films because they're not going to expect you to read scans. Treatment, again, is preservation of the femoral head with preserved normal range of motion and, in general, non-operative. So, avascular necrosis of the femoral head, remember sickle cell and long-term corticosteroid. Scoliosis, you can see the obvious curve here. 10% of curves progress and require medical intervention, and only when the curve is at least greater than 10 degrees. I think you're all pretty familiar with how to screen for scoliosis. However, remember that the Academy does not recommend routine scoliosis screening. It's not part of their screening recommendations. And you can see the various physical findings that are outlined here. Scoliosis classification may be infantile, juvenile, or adolescent, with adolescent being the most common. You've heard several syndromes that are associated with scoliosis. Keep those syndromes in mind. Neurofibromatosis 1, and one final cancer lookalike, and that is McCune-Albright syndrome. Because remember, McCune-Albright syndrome, in addition to scoliosis, has fibrous dysplasia. And those are real ratty-looking bones. Although it doesn't hurt, it looks very concerning. But the description of McCune-Albright will be included as premature puberty or thyroid disease. And again, remember the large café au lait spots with jagged borders, the coast of Maine. M for Maine, M for McCune-Albright. So that is one additional cancer lookalike. So scoliosis, I'm not really convinced that they're going to ask you how to diagnose it, but I am quite sure that you'll have some scenarios that include scoliosis as a component of a particular syndrome. And the determinants of progression are pretty straightforward, as is that. Okay, we talked about scoliosis. Okay, and don't forget that scoliosis is also associated with Marfan syndrome. Okay, you've also heard about Marfan's. One other board tip. Remember, we've talked a lot about lookalikes. We talked about Turner's and Noonan's, for example. Remember, the lookalike for Marfan's is homocystinuria. So the Marfan-like patient who presents with a stroke is homocystinuria, because large amounts of homocystinuria cause damage to the vascular endothelium. And that's why these individuals are at risk for thromboembolic events. So the cardiac complication of Marfan's, dilation of the aortic root, it's not really a cardiac complication, but the complication of homocystinuria is thromboembolic events. One more common lookalike, because again, they love lookalikes. Infant of a diabetic mother and Beckwith-Wiedemann syndrome. So a child with Beckwith-Wiedemann syndrome is going to be born, and they're going to say, large child, recurrent problems with hypoglycemia. Oh, that sure sounds like an infant of a diabetic mother. And then they're going to say something like this, following a normal pregnancy. Okay, so a normal pregnancy rules out diabetes. But remember that Beckwith-Wiedemann syndrome, because everything's big, including the pancreas, is associated with a big baby who's hypoglycemic. The other clue is that big baby may have an omphalocele. Okay, so I hope it's not ad nauseum, but I want you to remember that lookalikes commonly show up on the boards. All right, so if you hear gymnastics, weightlifting, a lineman for football, or ballet dancer with back pain, they have spondylolysis until proven otherwise, a fracture of the pars. So we've talked about limping 2-year-olds and then limping 8- and 9-year-olds. Now we're going to talk about back pain, and back pain in a gymnast, etc., is spondylolysis or a fracture of the pars. It gets worse as you bend backwards or standing with straight legs. And spondylolysis, again, is a fracture of the pars, usually the 5th lumbar vertebrae. Start with a plain film, but if it's early on, the better test is a bone scan. And don't misdiagnose it as a muscle strain, and the way to differentiate that, if they give you the option, is, again, increased pain with straight leg raising. Now, if it slips, this is spondylolisthesis. So fracture plus slippage, and usually, I think I've got an x-ray, slippage is right here, L5 on S1. So the description in your scenario will be back pain, and on physical exam, palpation of a drop-off. And that drop-off is because of the dislocation forward. So spondylolisthesis is more symptomatic than is spondylolysis, but again, a cause of back pain. So as you go down the spine, if you feel a step off, that means something has slipped, and that's probably spondylolisthesis rather than just plain spondylolysis. And the scenario, again, would probably likely be a ballet dancer, gymnast, etc. And treatment for this is just depending upon the degree of slippage. But certainly if the degree of slippage is associated with problems with defecation or urination or lower extremity neurologic findings, then that patient needs to be evaluated further. And then the famous SCFE. Okay, so this description, again, another limping child, but this limping child is now a teenager, usually in the early part of adolescence, oftentimes obese, somewhat more common among the African American population, usually during growth spurts. Again, limp. And where's the x-ray? There's the x-ray. So you can see here that this is the kind of what's described sometimes as the ice cream falling off the ice cream cone. There's the ice cream cone. And the cone should be more like that. This is not as severe a slippage as sometimes. And this will require immediate surgery, unlike leg Perthes disease. It can be diagnosed by plain film or by MRI. So SCFE, a little bit older age group, very different treatment. Needs to be pinned, needs to be seen immediately by orthopedics. Okay, so before we do that, let me just review. A limp in a 2-year-old, it's either transient synovitis or septic arthritis. A limp in a 9-year-old, leg Perthes disease or avascular necrosis. Limp in a 14-year-old, SCFE. Back pain, think spondylolysis. Back pain with a, thank you, step off. All I could think of was bump off. That was a petit mal seizure. That was my 4th one. With a step off is spondylolisthesis. Thank you. Osgood-Schlatters, my knee hurts, when in actuality on physical exam it's not the knee but the tibial tuberosity. So this is the volleyball player or the basketball player, not the ballet dancer or the gymnast. Okay? And usually occurs during the growth spurt and secondary to repetitive contraction of the quadriceps. Typically asymmetric, although both knees are relatively commonly involved. So what happens is that the ligament comes down, attaches to the tibial tuberosity. That attachment is not particularly strong, so there may be a small bony fragment that is avulsed off of the tibial tuberosity, leading to oftentimes visible, painful swelling overlying the tuberosity. So again, although the chief complaint is my knee hurts, the description in the vignette will be centered around pain at the level of the tibial tuberosity. And oftentimes this swelling persists. The pain goes away, but the swelling can persist for life. Okay, you do not have to evaluate these individuals any further. So if you're given a scenario that is just typical of Osgood-Schlatters and you're given the opportunity to reassure and treat symptomatically, that's your answer. You do not have to work these individuals up further. Now, if this individual presents and this pain is waking him up at night, well, that's a different story for all the reasons that we talked about. But the scenario will not include any worrisome systemic symptoms, and you can therefore not evaluate. Here's an example. You can see the swelling visible on X-ray. You can see the tubercle and the small avulsed part of bone right there. Treatment is conservative. You tell the individuals not to play volleyball, not to play basketball, then they go and they play volleyball and they play basketball. So it's sort of a battle between symptomatic treatment, but most adolescents are not going to stop. All right, now, what is different about back pain that's associated with discitis? We talked about back pain, but now this is back pain with point tenderness. And that's the key that should tell you that something is going on in the disc space. So there's no step off, but there is now point tenderness in the limping individual. Discitis is a low-grade infection. In fact, a lot of people say that many people get discitis and get better on their own and you never know it. But if it is diagnosed, the bug is invariably going to be Staph aureus. It's an indolent infection, and the typical scenario is a normal CBC with elevated acute phase reactants. Bug is staph when it is isolated, and fever is only present in at most a third of the patients. And let me see here. So this is what it looks like. This is obviously very advanced, but you can see that the disc space is almost totally obliterated by the narrowing, and oftentimes inflammation of the disc is also associated with evidence of osteomyelitis. So discitis may occur alone, or it may occur in conjunction with osteomyelitis. And that's why your recommendation in general, if this is when this patient is presenting, this is an individual that I would not rely on plain films, but I would go to an MRI. And the reason for that is you really need to get a better look not only at the disc space, which will be narrowed, but at the adjacent vertebral to see if there are any lytic lesions that would suggest an associated osteomyelitis. Okay? Again, the white count's usually normal, big clue, because you don't really think of normal white counts with infection, but the SED rates are SED rate and CRP are considerably higher. Blood culture, excuse me, usually sterile. Okay, so speech and language development. For the test, we plan to memorize and understand when major language milestones occur and when to refer when milestones are not met, always focusing on early intervention and always focusing on the status of the ears. So you're checking the hearing, you're making sure you're not dealing with acute otitis media, or you're not dealing with otitis media with effusion for the last 6 months. So you need to know normal development, and in many ways, the next group of slides, really very similar to the substance abuse slides, are slides that you really have to commit to memory, and you don't necessarily need me up here reading the slides to you. But for developmental milestones, language milestones, you really need to be very familiar with those. So again, you can make a decision as the vignette is presented to you as to whether or not the child is developmentally delayed or not, because they might not tell you he or she is developmentally delayed. They might just describe a 10-month-old doing these various things, and they're going to be asking you to make the decision as to whether or not they are developmentally delayed or not. So localizing sounds, cooing then becomes babbling, consonants are added to vowels, and mama and dada begin to be formed. In 6 to 10 months, 10 months is really, that's on the latter side. 10 to 18 months, there's rapid acquisition of names. Somewhere in the neighborhood of 100 words are probably understood by 18 months of age. This is the period of time where there's not only first words other than mama and dada, but the understanding of considerably more words, and parents should be advised to point while speaking. Let's get the juice. Let's pick up your banana. Let's go here. Not allowing the child, as they get older, to express his or her wishes by pointing. And it's very different. So pointing is good when it's a parent talking out loud. Responding to pointing, if this means juice and that means I want to go to bed, is bad. Okay? I think probably some of you want to go to bed now. You've been here all day for that. Okay, start combining words around 15 to 18 months of age with sentences. Again, there's a lot of variability between these, but just keep these developmental milestones in mind. Now, more importantly, what are the red flags? Absence of babbling by 9 months, absence of any words by 18 months, absence of meaningful phrases by 24 months. 25% of speech is unintelligible to strangers at 3, or any speech is unintelligible to strangers by 2. So one thing, remember this, 50% by 2, 75% by 3, 100% by 4. That's the amount of language that should be understood by strangers, not by parents. The definitions are here in terms of difficulty in speaking versus the loss of or deficiency in or the power to use and understand. So there's a big difference between difficulty in articulation and an inability to speak. Again, the former being much more likely associated with underlying central nervous system insults. And hearing loss, the definition is here, but surprisingly, even a 15 decibel loss can result in problems with speech perception. And this is what prompted a lot of studies on otitis media with effusion. Because obviously, if you have a 15 decibel loss that's going to interfere with speech, maybe we ought to intervene much more quickly than I just suggested a little while ago. And very specific studies have shown that it is safe for at least 3 months to watch middle ear effusion. And some of those studies suggested that the children might be a little bit behind, but quickly caught up. So again, not to worry with watchful waiting. Now, age and task by breakdown, task by age breakdown. Again, this is really for your study. I don't think that I'm going to be particularly beneficial by reading here, but normal child development is outlined, and this is what we're going to finish up with. So this youngster can sit well without support, pull up to a stand and cruise, feed herself finger food, point to an object of interest, raise her arms to be picked up. She can play peekaboo. She does not follow one-step commands, nor does she ask for things by pointing. Doesn't ask, she points, but she doesn't ask for things. So how old do you think this child is? 6, 9, 12, 18, or 24 months? Okay, good. So, again, you might get a few questions like this straightforward, but I think that those will be in the minority. But it is worthwhile for you to look through these sides, and we can look at age, task, fine and gross motor, cognitive, language, and social. And so it's all here. There are motor skills, both gross and fine, for each of the age groups. Cognitive skills for each of the age groups. Language and social skills for each of the age groups. And it goes from 3 months all the way up to 6 years of age. All right.